Hi, welcome to the lung page. Today we are going to see fitness to fly, assessing air travel risk in respiratory diseases. So, for an example, patient with COPD or bronchiectasis, any thoracic intervention was done or pneumothorax patient. So, these type of patient they are going to fly. So, what are the things we are going to assess? Who are the patient fit for fly? So, we will see one by one. Okay, first we are going to see the physics of the cabin. Usually the sea level we all know, yeah, that is usually we are living environment. When we go to the up, usually we are taking 8,000 feet because the domestic flight usual limit is 8,000 feet. So in this 8,000 feet, what will happen to the environment, that particular environment? That cabin, you all know, definitely there's a partial pressure of the oxygen is drop, and also gas become expand and humidity become drop. So these are the physiological changes happen during the flight time. So in this setup, how our body become adapt? So what we are going to do, so we'll see one by one. Okay, now we are going to see what are the absolute contraindication, what are the relative contraindication, or what are the things we have to need specialist input. Here we can see absolute contraindication, mainly untreated respiratory failure and untreated pneumothorax and active or contagious diseases like TB, SARS or COVID, and sometimes bronchiogenic cyst. These are the absolute contraindication to fly. And what are the specialist input needed? So usually this patient have a FEV1 less than 50 or recent or less than 6 week hospitalized treatment for pneumothorax and respiratory muscle weakness, and also patient on a CPAP or NIVO, sometimes patient on oxygen. These type of patients need a specialist requirement for the review for before the flight. Okay, when we take infant and children, so the preterm infant less than 37 weeks, so usually they are not going to fly. So if they are going to fly, usually need a minimum 1 liter per minute oxygen is needed. So HCT means hypoxic challenge test, not recommended in this group. So the term babies more than 37 weeks. So after 1 week of the delivery, these babies are can fly. So in the pediatric population, patient infant less than 1 year, usually chronic respiratory problems is there, and also some chronic diseases like cystic fibrosis or primary ciliary dysfunction with FEV1 less than 50 and recent oxygen use. These type of pediatric population need a HCT. HCT mean hypoxic challenge test. We'll see in later. So what is hypoxic challenge test? Hypoxic challenge test means pre-flight oxygen test. That is not a fitness to fly. So that means we'll create the exact situation around 8,000 meters in the flying cabin. What will happen in the oxygen levels? So usually oxygen level is drop and also hypoxia will develop. So we'll create that same environment in the clinic setup. So we'll measure the uh, oxygen levels. So who are the people not needed? Usually stable patient. The COPD patients baseline saturation is more than 95, and COPD patient who do not desaturate less than 84% in the 6-minute walk test, and also patient with significant past intolerance to air travel. So this type of patients need 2 liter per oxygen directly, so without doing HCT. So hypoxic challenge test, we'll do the step-by-step procedure. So patient preparation is very important and obtain the written consent, and we'll measure the baseline saturation and blood pressure and baseline ABG and heart rate, respiratory rate, everything should be measured in the baseline, and ABG should be measured. So we'll create the hypoxic environment. We'll create these two methods. Previously I told we'll create this hypoxic environment in the clinic setup as the same as in the airplane in the 8,000 feet. So ask the patient to breathe FiO to 50%. So we'll create this gas mixture with FiO to 15% with 80%, 85% nitrogen through the tight mask and non-rebreathable circuit. And second method is nitrogen dilution. So with that, ask the patient to breathe 20 minutes. So in these 20 minutes, we have to measure the saturation, heart rate, symptoms, and observe the symptoms like dyspnea, dizziness, and chest discomfort. So within that period, after this 20 minutes, we'll again measure the blood gases. After the 20 minutes, obtain the blood ABG while still breathing the patient with this FiO to 15 percentage. So that ABG will measure the partial percent oxygen, carbon dioxide, and pH levels. So interpretation is very important. PO2 level is more than 50 with this hypoxic environment, and saturation more than 85. So this patient is safe to fly. Though these patients no need oxygen, and saturation is less than 50. And sorry, partial pressure is less than 50 and saturation less than 85. So that means significant hypoxemia. So these patients need oxygen. So in these patients, we'll need oxygen titration. So we'll give the oxygen titration with that environment. So start the supplemental oxygen and repeat the test while titrating the oxygen. Then we'll determine the what are the oxygen flow rate or requirement flow rate. So this is a simple step of hypoxic challenge test. So assessment algorithm, obstructive airway disease patient. So as I mentioned previously, the patient saturation is more than 95 in the room air. Yes. So MMRC score is less than 2. So these patients are no need oxygen. So if the patient is already on LTOT, yes, type 1 or type 2 respiratory failure we have to assess. So if the type 1 respiratory failure, this patient need a 2 liter per minute or greater than oxygen during the air flight. And a type 2 respiratory failure patient need a hypoxic challenge test. Like that, we'll assess the obstructive airway disease patient. Like that, restrictive airway disease patient, like ELD patients. So patients need a pre oxygen or HCT. So how can we decide? Saturation is less than 95 or 6-minute walk test or shuttle walk test. So saturation not drop to less than 95. So this type of patient no need a HCT or no need a oxygen requirement. Is the patient saturation drop or is the patient on the LTOT? Yes. If the patient the LTOT means long term oxygen therapy. So this type of patient need a oxygen in the airplane 2 liter per minute. So if this patient not on the LTOT but saturation is dropped during the 6-minute walk test, so we'll assess the total DLCO. So DLCO is less than 50. So less than 50 need a hypoxic challenge test. Not less than 50. So this patient not need a oxygen. So like that we'll measure the restrictive lung disease patient. So interpreting the HCT as I mentioned previously. So partial pressure of oxygen is more than 50 or saturation more than 85 during the HCT, the patient can proceed or fly. So if the patient less than 50 and saturation is less than 85, so we'll need a titration to maintain this partial pressure of oxygen more than 50 during the flight. So red flag symptoms. So who are the people are not flying? So monitoring the pH and PCO2 for type 2 respiratory failure. Advice against travel if the pH is for less than 7.35 and PCO2 increase more than 1 during the baseline from the HCT. So these type of patients are against travel during the flight. So managing airway obstruction. Asthma patients always almost keep the inhalers. In severe asthma patients require hypoxic challenge test and emergency oral corticosteroids. A treatment should be carried during the plane, and also food allergies are there, we have to avoid. COPD patient avoid travel within 6 weeks of exacerbation. So that's very important. And high risk patients need a venous thrombus prophylaxis, and also patient need to carry the plan of management during the exacerbation. Cystic fibrosis or bronchiectasis patient is FEV1 is less than 50 predicted, strictly need a hypoxic challenge test, and also regular airway clearance is essential on long haul flights, and airlines must approve portable nebulizer. So PEEP devices during is advisable. So this is how we manage the obstructive airway. So interstitial disease or restrictive disorders, ILD patients are unlike COPD. So ILD patient can tolerate hypoxemia poorly. So sea level SpO2 does not reliably predict on during flight. So these type of patients need a hypoxic challenge test. So chest wall disorders patients also need a hypoxic challenge test. So these type of patient advisable during the daytime flight. Hypoxic challenge is highly recommended for all adult patients with FVC is less than 1 liter during the chest muscle disorder or restricted lung disease patients. So this is very important. What are the thoracic surgery or pleural disease timeline? So the once patient develop pneumothorax, so patient must wait for 7 days after full recovery of chest X-ray. So after that he can fly. So sometimes post bronchoscopy biopsy, the patients need 7 days. Sometimes patient need a major surgery, thoracic surgery, bad so open surgery. So this patient need essential to fly. So usually take rest for 2 weeks and get surgeon approval. So non-essential air travels. So after surgery, patient need to take rest for 4 weeks. So sometimes trap lung or cystic lung disease, LAM or Brodhead's Dubé require high specialist opinion. Venous thromboembolism on pulmonary hypertension are very important. So these patients and rule delay air travel for minimum 2 weeks of post diagnosis. This is very important. So prophylaxis for high risk patients on long hauls flight, nearly 6 to 2 weeks flight. So we have to start low molecular weight heparin, enoxaparin 40 milligram or prophylactic we have to start. Sometimes patients have a pulmonary hypertension. So NIHA WHO classification 3 or 4 usually advised to have flight on, during the oxygen. So management administer 2 liter per minute by nasal cannula or titrate via hypoxia challenge test. Ensure the patient has sufficient oxygen for entire journey. So this is how we manage the pulmonary hypertension and pulmonary embolism. Some patients have a sleep apnea, obstructive sleep apnea, or some dysfunctional breathing disorders. How can we manage during the air travel? So this time, these patients have to advise take daytime flights if possible. Avoid sleeping if unassisted. Avoid alcohol and sedative 12 hours prior to the flight, and carry CPAP. That machine should be approved by the uh, airline authorities because of the battery. And dysfunctional breathing and hyperventilation patient can mimic the asthma but unresponsive to bronchodilators. So rebreathing via back is not recommended due to the severe hypoxic attack. So in this patient we can differentiate whether it is asthma or not. So we have to give the supplemental oxygen for this dysfunctional breathing or hyperventilation patients. So equipments is very important. So have to keep the battery for nearly 6 hours battery. For an example, 1.5 rules. So with the flight is 4 hours, so we have to keep the battery for 6 hours. Sometimes portable oxygen concentration also very important. So during these type of patients, so if it is airline approved portable oxygen concentration, we have to carry. So this is a summary list we have to know. Screen for the absolute contraindication. Exclude the untreated respiratory failure, active infection, and untreated pneumothorax. So this is very important. Second, check the post-procedure timeline. Ensure 7 days post pneumothorax and 2 to 4 weeks post surgery and 2 weeks post venous thromboembolism. That is very important. So some patients need a hypoxic challenge test. So these type of patients, some mainly FEV1 less than 50 and postal vital capacity less than 1 liter, and ILD with DLC on PCO ratio is very low, and history of hypercapnia. These type of patients need a hypoxic challenge test. With that we have to titrate the how many liters of oxygen needed, and we have to prepare the titrated oxygen with a preparation. Targeted oxygen saturation is PO2 is more than 50 and PC and saturation is more than 85. So and also ensure the battery life. And another important thing is optimizing pack smart. Hand luggage full of inhalers, CPAP, and updated management plan that will almost all the equipments should be verified by the airline approval. So this is a summary. Now you can clear about fitness of flight. So this is my page. Please subscribe and follow in the Facebook page and follow in the TikTok. Bye.